Bismillahirrahmanirrahim. Hi everyone. So we get to the last video of the series for discussing hyponatremia. Today we're gonna talk about the management of hyponatremia. Again, this is a quiz from the last video. If you haven't seen it before, again pause the video and see if you can answer the question, and then we're gonna talk about the answer in the next slide. So this is a 59-year-old male with hypertension, hyperlipidemia, and anxiety, admitted with a sodium of 123 and some symptoms, vague symptoms, which might be attributed to hyponatremia, among other diagnoses: fatigue, nausea, headaches, and vomiting. He's taken some medications that can cause hyponatremia, including citalopram and chlorthalidone. Rarely, lisinopril and ACE inhibitors can cause hyponatremia, but these two are much more common, the citalopram and chlorthalidone. Now the question is, which of the following tests will support the diagnosis of SID in this patient? So let's take the first one: urine osmolality of about 300, so it's more than 200, so that supports SID. Measured serum osmolality being normal, so that does not support SID. We mentioned that in SID the measured osmolality should be low, in accordance with the low sodium. So if the measured osmolality is normal, this is pseudo hyponatremia. Urine sodium of 21, this is really low. In SID expected to be higher than that, usually more than 40 or more than 30 to 40. Normal TSH, yes, you need to check for that for most patients suspecting SIDH, and some experts say in all patients. The same for serum cortisol. Secondary adrenal insufficiency can look like SID. Serum uric acid being in the lower side, less than 4, yeah, that might support the diagnosis of SID. We don't know exactly why it's low, but partly because of loss of uric acid in the urine as part of the compensatory mechanism in natriuresis. And then lastly, serum sodium improved with to 128 with saline infusion after 6 hours, and we mentioned that in hyponatremia due to SID, fluid is actually can make it worse, or it's not expected to improve the hyponatremia. So treatment is actually fluid restriction, among other parameters that we're going to see in this video. Okay, so let's talk about acute severe hyponatremia. These are the patients who were okay at baseline, and then all of a sudden they developed neurological symptoms, seizures, severe headache, obtundation, altered mental status. For example, patient after surgery who had been giving some hypotonic fluids, patient was unaccustomed exercise, or marathon runners, or any severe exercise, who had been taking some hypotonic fluids. They can develop acute hyponatremia, and they can be severely symptomatic at the beginning. So how do you manage these patients? So basically the first step is, these patients need ICU, or at least step down unit if they're a little bit more stable. So you have to think about allocation of the patient management. This patient really sick and they can deteriorate quickly, so it's very important that they have close observation and close monitoring. So your first goal is to alleviate the acute symptoms by increasing the serum sodium by 1 to 2 millimole per hour to a total of 4 to 6 millimole. As you know, and we'll talk about that in a few minutes, usually the goal is to raise in a patient with hyponatremia is to raise the serum sodium by up to about 8 to 10 millimole in the first 24 hours, and then up to 18 millimole in the total of 48 hours. Now you need to go a little bit faster when the patient is acutely sick, so you want to raise it by this rate in this patient. How do you do that? Or maybe give you an example. If you have a patient with a serum sodium of 110 and they're severely sick, obtunded, altered mental status, you think they're having severe acute hyponatremia, then probably you want to raise it to about 114 to 116 over the next 4 to 6 hours. And then after you reach this goal, then you can increase it up to, for example, 124 over the next 24 hours. So you go from 110 to 114, 116, and then from 114, 116 to 124 after that. So how do you do that? Usually hypertonic saline is a type of fluid that we use. So how do you calculate the dose, how much you give? It's very variable. There's no like one single equation. Some people might consider different methods. So before you do that, you need to know that a liter of the hypertonic saline has about 430 millimole, and that the 100 ml of this concentration of saline can increase the serum sodium by about 1.5 or 2 millimole per liter. That's considered like a bolus of hypertonic saline. So keep that in mind. Maybe a rough estimation or a simpler way to do that is to give a bolus, which is about 100 or 150 ml over 20 to 30 minutes, and then check the sodium again and see if you get to the how much is the level, and then you can repeat this doses as needed until you get to the goal of the acute management here. So this is a rough estimation, but it's simpler and it makes the management a little bit easier. If you want to be a little bit more fancy, you can do the calculations, especially if you like math. You can calculate the whole amount of sodium deficit, how much millimole of sodium you need to give for this patient, and it's done by multiplying by calculating the total body weight, which is about 0.6 of the total of the body weight, because our body is 60% water. It could be a little bit more, could be a little bit less, depending on the gender and depending on the fat component. But roughly 0.5, 0.6 times the body weight in kilogram would be a good estimate. And then you multiply that by the difference between the target sodium and the sodium that you have. So if the patient have a sodium of 110 and your target is 116, that's 116 minus 110. So you multiply that by the body weight. If the patient had, let's say, 100 kilogram, 100 times 0.6, this is 60. And then you multiply 60 times 6 is 360. So 360 of millimole of sodium, that's the total amount that's needed to raise the sodium from 110 to 116. And then you can calculate the rate accordingly, knowing that the liter of the hypertonic saline has 513 millimole. Also, kind of another estimation is using the weight is if the patient is really sick, then maybe they're in coma and you think it's all because of the hyponatremia, you can give a really high dose of 5 milliliter of the hypertonic saline per kg per hour as a bolus. If the patient is less severely sick, you can give half of that, or you can give even much less. You can give 0.5 to 2 millimole per kg per hour. So all these are really kind of estimation. So the most important thing is really to kind of check the serum sodium periodically and regularly, because that's the only way you can tell whether you're under treating the patient or over treating the patient, and you want to make sure that you don't cause complications or over treat your patients. And the only way to do that is really to check it after every bolus or to check it hourly. And that's one of the reasons why the patient needs to be in the ICU or step-down unit, because the nurse to patient ratio is a little bit less and they can do that more regularly. And the patient will be sick anyways to be in the floor. So yeah, keep that in mind. That's really important. You have to make sure that you follow up on the serum sodium periodically to make sure that you're not under treating the patient or over treating the patient. So many complications can happen. Acute pulmonary edema is one of them. Can give some diuretics if that happens. Also, hypercapnic respiratory failure can also happen. Cerebral edema and herniation can also happen with these patients. So be careful. You have to do periodic neurological examination of this patient and periodic checking of serum sodium. And meanwhile, you can start to think about the underlying cause and try to tackle that as well. And the last thing to mention is that ADH or ABB antagonists, they do not have any approved role in the management of acute hyponatremia, because they can really make things worse, and they can precipitate severe overcorrection. So we'll talk about them as an option for other causes of hyponatremia in the coming few minutes. So how about patient with SID? So we talked about basic pathophysiology and compensation that happens with SID. So this is from the last video. So I'm just going to over the options that you have and the step that you might consider in patient with SID to treat their hyponatremia. I'm going to take advantage of the basic pathophysiology and go over these steps and see which step can be tackled by which management plan. So maybe the most important aspect of the management is to treat the underlying cause of the increase of the ADH, right? We said in the last video about SID that most of the patients, not all of them, most of them had increase in the ADH, and this could be due to medications, due to malignancy, lung disease like infections or pneumonias, and cerebral disease. So you want to think about what could be driving the SID. So that's kind of as you're doing the workup for this patient, it's really important to try to tackle that. Some of these might be reversible, like for example, if there's the medication that's causing the SID and you can get rid of the medication, you stop the medication, and that hopefully should help resolve the problem, in addition to monitoring of the sodium and treat it gradually. But unfortunately, some patients with malignancy, for example, they might not have total resolution of their underlying malignancy, so they might expect to have some hyponatremia for some time, but you want to get it better, you want to get it close to normal. So bottom line, think about the underlying cause and make some effort to treat it. And then these patients, they continue to have water intake, partly because they have a stimulated thirst mechanism. So to counteract that, you might do some water restriction. As you can imagine, this is not easy because the thirst center is telling the patient to drink water because thirst is stimulated, but you're telling the patient to do the opposite. You're telling the patient to restrict their water. So it might be difficult, it might not be easy, but you still have to try it as one of the management steps for SIAD. So how much you restrict the patient, there's no rule of thumb. You can try 1.5 liters a day, you can try less than 1 liter a day. You can use equation if you like equations, a total urine volume per day minus 500. So if the patient urinated 1500 in the last 24 hours, then you want to restrict them to less than 1 liter, and so on and so forth. Also, you can do more severe restriction, like less than 800 or less than even 500 ml per day, which is really hard. By using this equation, it's just telling you that there's really a very high ADH level and you need to restrict the water a lot to get some benefit. Again, that's the more strict the policy is for the patient management, the harder the compliance would be. Also, if the urine osmolality is really high, more than 500, it means there is really a very high level of ADH, and that will make the water restriction less effective. Water restriction generally is hard, but still you can try to do it, but you don't really expect that it might solve the problem altogether. What else? So we talked about the natriuresis and why we mentioned that we don't know why it happened, but there are some theories. But to compensate for the loss of salt and electrolytes by this mechanism in SIAD, then you can try to increase the serum sodium by giving salt tablets. So the tablet of the salt tablets is 1 gram. So you can give about 2 to 3 grams every 8 hours, in addition to the monitoring of the serum sodium, right? Urea tabs, I haven't used it before, to be honest. I've heard that the taste is not really good. I don't think it's widely available anyways, but it's also kind of it also can help with this mechanism. And also you want to replace the potassium because normal potassium will help correcting the hyponatremia. So salt tablets is commonly used for SIAD patient. And then you can target the kidney as well. So remember we mentioned that the loop diuretics doesn't cause hyponatremia such as thiazides because it works in the medulla, and it make the action of ADH blunted or less effective. So also a patient with SID, they might be a little bit hypervolemic, so diuretic can help with these sites. So you can try use furosemide, small dose oral furosemide as an adjunct in the management of this patient. Democlocycline also work in the kidney, but it has some kidney toxicity. Also, I haven't used it quite often. Tolvaptans are ADH or ABB blockers, so they also work in the kidneys. So you can use them as an option if the patient expect the patient to be hyponatremic for some time, but they need careful monitoring. We'll talk about them in the coming few seconds. So these are the kind of most of the options, or the options that you have for SIAD. Remember that if you give this patient normal saline because, for example, you think that they're hypovolemic, then it's not going to correct the problem. It actually might make the hyponatremia a little bit worse. And the patient might be a little bit hypervolemic, so you're giving them volume. So normal saline is not really an option, except if the patient is hemodynamically unstable, they're hypotensive, tachycardic, you might consider giving them, you need to resuscitate the volume first before you tackle the hyponatremia. And this patient might need to be in the to go to the ICU for that as well, especially if they are hemodynamically unstable. And also we mentioned about hypertonic or 3% saline also is an option if the patient is having severe symptomatic, neurologically symptomatic hyponatremia. You might give hypertonic saline as well. Okay, now let's talk about in a little bit more details about the Vaptans or the AVB or ADH antagonist. We mentioned those as part of an option for management of patient with SIAD, but they can also be used in patients with hypervolemic hyponatremia. So these are really the main indications. Again, they can be effective in patients with IAD and patients with heart failure or cirrhosis. They have like hypervolemic hyponatremia. In addition to treating the underlying cause, then you sometimes might try to use the tolvaptans if the sodium is too low and you feel like the patient is symptomatic from the hyponatremia and you want to correct it. And the medical management with fluid restriction and diuretics and other measures are not really helping with correcting the sodium, then these are options to try. They work on the V2 receptors on the kidneys, and they block the action of the ADH on the V2 receptors in the kidneys. So they cause what's known as aquaretic effect, meaning just augmentation of water clearance. So the patient will be urinating more water, and there will be block of water absorption because of the block of the action of the ADH. So there's only 2 of them approved by the FDA, but on the time of this video, there is a tolvaptan which is available orally, and as far as I know, it's the only oral AVB antagonist that so far is being approved. And there is a conivaptan, which is only available IV form. This IV form, the conivaptan, it has a mixed V1A and V2 antagonism. So acting on the vasculature, as you can imagine, they might cause vasodilation or prevent vasoconstriction, and they might increase the risk of hypotension. So you have to monitor for that. There is some requirement by the FDA kind of for safety and things you have to consider when you're starting a patient on the tolvaptans or the Vaptans. So these medications, they need to be initiated in the hospital, and that's because it can cause overcorrection of the sodium. So you want to make sure that the patient that's not the case, and you want to make sure that it's safe to correct the sodium in a gradual way. So if the patient has been on this medication before and you want to reinitiate it in a later time, you have to also kind of consider close monitoring, ideally in the hospital setting. You don't want to restrict the patient from water. We do that in the beginning of the first measures to treat SIAD, but once you decide to start this patient on the Baptans, then you need to allow them to drink water, because if you don't do that, then it can lead to overcorrection, and patient might get hypernatremic actually really quick, and that's why serial measurement of sodium is really important. That's really key. Or have to monitor the sodium periodically. And because of the liver toxicity, it's not recommended that you use this medication for more than a month or two. So it's really a temporary measure. You're hoping that during this time you try to tackle the underlying cause and treat the underlying cause, and that should help correct the sodium. But if you have to use it, then use it for more than 1 to 2 months because of the side effects. And they're usually less effective or unlikely to work if the serum creatinine is more than 2.5, for example, or the patient has chronic kidney disease or kidney dysfunction. You might try it, but it's unlikely to work in some patients. And as you can imagine, it's contraindicated in patients with hypovolemic hyponatremia, because these patients are volume down. So if you give them aquaretic effect and you increase the water loss, that can lead to severe hypernatremia and volume depletion, and that can make things worse. So that's kind of a summary of these medications. I think I have used them once or twice before. They're not really very popular because of all these requirements, but it's still an option if you feel like you want to correct the sodium in patient with resistant SIAD or resistant hyponatremia is a setting of hypervolemia. Now, what if you feel like the hyponatremia is overcorrected? We talked about the goal of correcting the hyponatremia before, and we mentioned that you don't want to go beyond 8 to 10 millimole per liter in the first 24 hours. And or more than 18 millimole per liter over 48 hours. So this is kind of your target, and this is all to prevent the rare osmotic demyelination syndrome. Now, who are the patients that you need to pay a little bit more attention to in terms of them having higher risk to develop overcorrection and ODS? We talked about that before. Patient with malnutrition, patient with alcohol, patient with liver disease, patient with hypokalemia, patient who has severe hyponatremia to begin with, patient who have readily reversible causes. For example, patient with hypovolemia, once you start to give them fluid, they might overcorrect and they might respond really quick. We talked about the patient with T and TOS hyponatremia. Once they get admitted to the hospital and started on a normal diet and maybe given some fluid, also they can overcorrect. A patient with adrenal insufficiency, once you diagnose them and start them on steroids, they also can overcorrect. We talked about the effect of cortisol and how it can inhibit ADH synthesis and secretion. The use of AVB, we just talked about that, and the need to make sure that the patient is not on fluid restriction and they can drink water, and close monitoring to prevent overcorrection. So these are the group of patients that you really want to pay more attention to. So what if it happens? You want to really correct that quickly, because patient in the future might develop ODS in few hours, few days, or even a week or two later. So you stop the active ongoing treatment, whatever you're doing to correct their hyponatremia, you stop that. And then you want to retain some water, so you do give them back the ADH that you try to inhibit before, and we do that through the ADH agonist. The one we have here in the United States is desmopressin. So you can give an IV dose of desmopressin 2 to 4 microgram, and you can repeat that every 8 hours, and that will help retain water and prevent the sodium from going up. And then you can give a bolus of the D5W or hypertonic fluid to bring it down. So if you, let's say within 4 hours, the sodium went from 120 to 127. That's kind of a big jump, and you want to bring it down to, let's say, 124 or 123, for example. So you want to stop it there first. So you stop what you're doing, and you give the desmopressin, and then you start the patient on D5W. How much you give, it's sort of estimate. You can try anything between 3 and 10 ml of kg per weight, depending on the weight of the patient, and you start them on that over an hour, and then you check the serum sodium, and then you depending on the level, you decide whether you want to give them another bolus or not. And that's why serial monitoring is really important in these patients. That's the only way to tell if you're really correcting the overcorrection. So these are the two measures that we usually do, the desmopressin and the D5W, to kind of make sure that the patient is not having overcorrection and they're not getting into ODS.